Well, first of all, thank you very much. I'm really delighted to be able to come to this workshop, and so I thank you all for inviting me. Although I do notice that I have the danger spot, the third talk after lunch. So to the degree that I can do it, I'll try to make this a little entertaining. So as was just mentioned, I'm going to be talking about the work of the U.S. Preventive Services Task Force. I know I've gotten a lot of questions about this over the course of today, and hopefully this talk will address those questions. So my goals for the next 15 minutes or so are to help improve the understanding of the U.S. Preventive Services Task Force, to explain the connection between the U.S. Preventive Services Task Force and the Agency for Healthcare Research and Quality. I just noticed, as a matter of fact, I'm the only non-federal employee standing up here. To describe how the task force develops recommendations, and then in the final period, to highlight child mental or behavioral health recommendations that the task force has made. So, the U.S. Preventive Services Task Force makes recommendations on clinical preventive services to primary care clinicians for use in a primary care setting. And so by that I mean these an unselected group of individuals, in this case children who are coming in for their routine well child care. There are three general topics that the task force addresses related to clinical preventive services. These are screening tests, counseling, and preventive medications. And the idea is that regardless of which route you go, the task force is addressing services that are either offered within the primary care setting itself or referred from the primary care setting to some other place. And again, I mentioned this before, but I really want to underscore this, so that the recommendations apply to adults and children with no signs or symptoms. So really what I'm talking about is primary prevention. So the U.S. Preventive Services Task Force makes recommendations based on rigorous review of existing peer-reviewed evidence. It doesn't conduct research studies, but it reviews and assesses the research that's out there. And it does evaluate the benefits and harms of each service based on factors such as age and sex, and we'll be talking about that later. And it makes population-based recommendations for primary clinicians based on patients' age and sex. And of course, any of the recommendations that the task force makes should be taken within the context of the individual patient in front of the primary care clinician. And then the other thing that, and this is why I made that federal comment earlier, it's important to recognize that the task force is an independent body of non-federal experts in prevention and evidence-based medicine. So again, I'm going to say that again, it's a non-federal panel. The task force members include 16 members across the broad swath of primary care. So family medicine, internal medicine, nursing, OBGYN, pediatrics, that would be me, and behavioral medicine. It's led by a chair and two vice chairs. Everyone serves a 4-year term. I'm the newest kid on the block, having just started in January. The way you get there is you're appointed by the AHRQ director with guidance from the chair and the vice chairs. And the current members include folk from academic medicine like deans and medical directors, as well as practicing clinicians and professors in healthcare. And I have the link here, and you should all get the slides so you can see who the members are. Now, it's important to recognize that AHRQ supports the work of the task force. So the AHRQ's overall mission is to improve the quality, safety, and efficiency and effectiveness of healthcare for all Americans. It provides administrative, scientific, technical, and dissemination support for the task force. So really, we couldn't exist without the fine work that AHRQ does. And I mentioned before about how you become a member. That's in partnership with AHRQ. And then finally, again, as I said before, it's a non-federal agency, and so AHRQ supports it, but the U.S. Preventive Services Task Force is an independent entity. So this is my kind of like how does a bill become a law slide. Where do topics come from in the first place? So anyone, as a matter of fact, those of you with your computers open right now can go to this link and nominate topics for the task force to consider. They can suggest a new Preventive Services Task Force or recommend reconsideration of existing topic if for example, evidence changes. We all know that new evidence comes out all the time. If there's a change in the epidemiology, the change in the public health burden of the condition, or if there's some new advance in technology, so if there's a new screening test, for example. So topic nominations are accepted all year round, and they're considered by the task force at its 3 annual meetings. We have another one coming up in July. So these are the steps in terms of how the task force makes a recommendation and how it interacts with the public. So the first step is creating a research plan. The second step is developing an evidence report and the recommendation statement. And the third step is dissemination. So I'm just going to highlight briefly how these steps happen. In terms of the research plan, the task force works with AHRQ-funded evidence-based practice centers to develop a research plan. That research plan is then put out on the task force website and public comments can come in. And then finally, a research plan for addressing the particular topic is developed. And then once that's done, there's a series of draft evidence reports, which once they are finalized to the task force's standards, it's released, and again, the public can weigh in. And then the evidence report is finalized, and after that, there's a recommendation statement. And then once the recommendation statement is done, the results are disseminated. In the interest of time, I'm going to go through this quickly because I think there are some other areas that you all may be more interested in. So this is the first issue that I wanted to address. So I picked here an example of screening, but the same thing would apply if we were talking about counseling or if we were talking about preventive medication. And that's the task force really looks at the whole process of prevention. So in the case of screening, it's not just the application of the screening test, but it's looking at whether or not the screening test leads to some long-term outcome. And so the task force uses an analytic framework that's tailored to the particular condition, and I'm just going to walk you through this briefly. In this case, this was the framework for considering screening and behavioral counseling to reduce alcohol misuse. It begins on the left with the particular population of interest. And then you can see where it says KQ1 across the top with the intervention. That's the overarching question, which is there direct evidence that screening leads to some change in long-term outcomes? Now, that's the kind of evidence that would come from something like a randomized trial of screening. That level of evidence rarely exists. And so what the task force does is sort of disambiguate everything. I don't know if I made up that word or not, but I hope it makes sense, which is looking first at whether or not there's evidence that there's a screening test that can identify what it is that you're interested in, and whether or not, as a next question, whether or not identifying that leads to some change in intermediate outcomes, and whether or not changes in intermediate outcomes leads to long-term outcomes. So when we think about long-term outcomes, we're generally interested in things that individuals can feel as opposed to an intermediate outcome, which would be some sort of proxy measure of things. Throughout the analytic framework, you can see with those little circles on the bottom, the task force also looks for evidence regarding adverse effects of whatever the preventive intervention is, or adverse effects of the intervention itself. And I think it's really important that we weigh both the benefits and the harms. And I can tell you that often in prevention, those harms are not explicitly looked for, but oftentimes they do exist. So once the analytic framework's done, it goes through the process of evidence review, where the evidence-based practice centers essentially does a systematic review. And in the interest of time, I'm not going to belabor that point. After that, though, there's a synthesis and judgment that the task force goes over, looking at the overall strength of evidence. That is the evidence convincing? Are there well-designed, well-conducted studies in the appropriate populations? Is it adequate? Does it seem like there's sufficient evidence to determine the effects on health outcome, but may be limited by the study design or that kind of thing? Or is it inadequate? Is there just insufficient evidence due to a limited number of studies or poorly conducted studies, underpowered studies, that kind of thing? And that's something you can march through with all the key questions. Those were the questions I had on the previous analytic framework. Once that process is done, the task force makes an assessment of the overall net benefit. The net benefit assesses the likelihood over whether there's a net benefit of preventive services. And once that's done, the task force also assigns a level of certainty to it. So I'm going to describe that again in a little bit more detail. Now, net benefit is kind of a conceptual thing. You can think of it as if you take the overall benefit and subtract off the harm. And so you can think about whether or not that's large in magnitude or small in magnitude and how certain you are about that net benefit. Again, in the interest of time, I'm not going to talk about the process for assessing certainty, but you can see how it can be ranked from high certainty to moderate certainty to low certainty. So, for example, studies may suggest that there's a large net benefit, but your conceptual confidence interval around it is really large because the evidence is just insufficient. Now, this is something that's, I think, if you take one thing away from this talk, it would be understanding the differences between the grades that are assigned once the exercise that we just went through is done. So A's and B's are those things where the task force recommends the service, and the difference is related to the level of certainty regarding the net benefit. But overall, the net benefit is substantial or moderate to substantial, and there's good certainty around that. Okay, a C evidence, or a C recommendation rather, is when the benefits and the harms are balanced, and there's moderate certainty that the overall net benefit is small. So the way to think about a C recommendation is that's something where you would want to really have a deliberate conversation with the patient to assess what their utilities are and whether or not the service should be offered, as opposed to A's and B's where there's fairly substantial evidence that it's the right thing to do, and in general it should be done unless the patient puts a strong disutility on whatever it is you're offering. A D recommendation is where the task force actually recommends against the service because the potential harms outweigh the potential benefits. Again, all these things can be modified based on what the individual patient wants. Now, what I want you to think about is the differences between those things where there's clear recommendations to the provider versus an I statement. I statements come up a lot, especially in child health care, because that's what happens when the current evidence is just insufficient to give it a recommendation. So there's I statements versus the A, B, C, D recommendations. Okay, is everybody with me? Oh, if there's not a nodding of the head, I'm going to perseverate and say that again. Okay, so I didn't see anyone not nod. So I statements are really important because it's important to know where the gaps are in our scientific knowledge. And as a matter of fact, the NIH looks at these I statements when it prioritizes what sorts of research needs to be done. We spoke, there was a lot of conversation before about the role of the Affordable Care Act and the U.S. Preventive Services Task Force. I just want to point out that the task force does not think about the economics of the recommendations that it makes. That's for someone else to do. The task force just looks at whether or not a particular recommendation is likely to lead to benefit for the population of interest. In the last negative 30 seconds that I have?
3 minutes.
3 minutes, oh, okay, now I'm gonna stretch back, I can take it easier. I just want to highlight where we are with the child mental health and development issues, and I'm going to be around at this meeting. If anyone wants to dive deeper into it, I'm happy to do it. So right now, autism spectrum disorder is in review. If you go to the website, you can see the draft review and sort of where things are. Speech and language delay was addressed in 2006. That one is also in the process of being updated. Previously, it was an I statement for children 5 years or younger. Alcohol misuse, so there's a theme here, right? An I statement for adolescents. Depression screening is being updated right now. That was previously a B recommendation for screening for major depressive disorders in adolescents 12 to 18 years old when systems are in place for follow-up, and an I statement for age 7 to 11 years. Illicit or non-medical drug use was an I statement. Smoking or tobacco use received a B recommendation for interventions to prevent the initiation of tobacco use. And this is actually an example of counseling that was asked about before. Suicide risk in 2014 was an I statement. Oops. And that's where we are with the child and mental health ones. And although I'd be happy to talk for about another hour, I'm actually going to stop to allow at least a couple of questions. How does that sound? All right. Thank you very much.